you everyone for a kind introduction. I'm Kang from UCSF. It's really nice to have to present this topic because I really truly think that I'm privileged to be living in this area, this era where myasthenia gravis treatment has extremely exciting for the treatment. So in next 30 minutes or so, maybe 25 minutes, we'll explore the evolving landscape of myasthenia gravis treatment. We'll review the history and latest advances in treatment. We'll discuss various therapeutic options as well as its mechanism of action. But if you have any question, please feel free to reach out. And I hope this talk will be really helpful for you to tailoring your own treatment because now it's a time to individualize the treatment for myasthenia gravis. So Dr. Goyal described myasthenia gravis mechanism so well, so I don't have to repeat. But I like to think the myasthenia gravis as like electronics with a very short battery life. It is described as a fatigable weakness. A lot of patients with the myasthenia gravis has a weakness and can function as normal, but its battery life is so short that it requires a lot of resting throughout a life. So it really affects everyday activities in terms of physical activities. So it's very devastating diseases. Myasthenia gravis was first recognized by Dr. Willis in London, and which was 17th century. So it actually was a long time ago when it was first described. But however, we didn't really understand pathophysiology of a myasthenia gravis. It's only been about less than 100 years that it's recognized as an autoimmune disorder and happens in between the nerve and muscles with the nerve neurotransmitter transmission. So I like to think our nerve and muscle communication like a phone call. This electrical energy from the brain is initially electrical energy, but it's transmitted to the chemical energy, which is called acetylcholine, and it's secreted in the nerve, and that binds to the muscle, which actually become a mechanical energy so that we can actually make a physical activation. And this delicate process is so well regulated. And for some reason, this antibody get produced by autoimmunity, then this communication become not very effective, and that is called myasthenia gravis. So we came a long way. It was initially described, as I mentioned, in 17th century, but the development of a treatment is only been less than 100 years. In 1930, initially the pyrrolystigmine and neostigmine was initially prescribed. This is a medication that's still used for our patient for the adjunctive therapy to increase the half-life of the acetylcholine in the neuromuscular junction. And that is due to the advances of understanding pathophysiology of myasthenia gravis. But even then, we didn't really know that it was actually autoimmune disorder. It was 1950 where the doctors were recognizing this may be autoimmune disorder. And it took 2 years to have steroid, which is kind of a most early treatment for any inflammation disorder, to become a mainstay of treatment of myasthenia gravis. Since then, as patient actually improves in their symptomatic, a lot of other anti-inflammatory drugs has been tried in many different courses of action throughout the years. And now we are really living in an exciting era that there is a lot of development with more targeted therapy with less side effects. Before we talk about a lot of exciting treatment for myasthenia gravis, I want to just touch base with the surgical treatment for the myasthenia gravis. Thymectomy was initially performed in 1930, which is very early, and I was surprised to hear about this history. The doctors were recognizing the patient with the myasthenia gravis has an abnormal thymus tissue, unlike others. And there was hypothesized that maybe if it is removed, then the myasthenia will be better controlled. And the first initial surgical intervention happened in later in 1930s, and it was further happened, the total thymectomy in 1950. there was a lot of controversy about this surgery, and it is open chest surgery, so it's not low risk surgery. And then there was a landmark study that I wanted to point out, which was published in New England Journal of Medicine in 2016, where they had the randomized trial with a multi-center with the patient with the myasthenia gravis without thymoma. And they actually found out that prednisone dose will be reduced in the patient actually underwent the thymectomy, and that is over 3 years. So it was not obvious improvement after surgery. However, it did show a lot of improvement compared to the placebo group where they only received the medication. So now it is one of the standardized therapy, especially for the patient with the myasthenia gravis in younger age. All right. Sorry, I hope I didn't make you bored, but I will discuss now about the overview of a treatment. In addition to thymectomy, I like to categorize the treatment by mechanism of action because that understanding this mechanism of action is really important because it can tailor our treatment and different combination of a therapy can be used. And we don't want to contradict each other by using the two different therapy will cancel each other. Overall, the broad immune suppression, T cell inhibitor, B cell inhibitors that has been traditionally used, and recently with more further understanding of immunological processes, FcRn inhibitor and complement inhibitor have been introduced. So first, I will go over the traditional therapy first. And traditional therapy is really targeted for the patient for the broad immune suppression. So as we study immunology, which is a very, very complicated process, Dr. Goyal described it as an army, and there are a lot of different parts of the army fighting against our pathogen. It starts with the innate immunity, which is the kind of a broad blanket to clump them together and remove from our body. There's a programmer, which is like a T cells who programs the actual pathogen, and they keep it in our memory so that if we get another attacks from them, there is a power there's efficiency to attack against. There's armies, which are B cell inhibitor, which includes the antibodies. And the myasthenia gravis is a T cell mediated antibody, B cell mediated also disorder with the pathogenic antibody, which is called acetylcholine receptor, which is most common. So you probably heard about the steroid therapy. This is the most commonly used therapy, and it's extremely effective, and it's very fast also. So it's commonly used as a first therapy for myasthenia gravis. When we talk about myasthenia gravis, as I mentioned, the mestinone or pyrigostigamine is used as adjunctive therapy for the symptomatic, but it's only a patch. So really attacking the immune system is crucial to have a better control over myasthenia gravis. Corticosteroid is one of the medication that has a broad inhibition of the immune system. And the doses varies, but a higher dose can make a myasthenia gravis worse. Therefore, it's very important to keep it in the kind of a medium size, but it's effective enough to control the disease. However, the downside of the steroid therapy is the side effect. There are too many to list. I didn't even include everything in here. And certainly the chronic side effect is the worst part because as we are on the steroid for a long time, it causes obesity, it causes changes in our face. Like one of the things that we say is a moon face is getting a lot of fat tissue around the face. Also, it increases the blood pressure. You can have a diabetes from it. It can, disturb your mood, sleeping pattern. There are so many things that can happen with the chronic steroid use. Therefore, all our clinicians and patients struggle with this medication is really to reduce the side effect by using different medication. Although we also want to take care of have a good symptom control over myasthenia gravis. Therefore, a lot of other therapy comes on, such as Imuran, azathioprine, Cellcept, tacrolimus, methotrexate. There are a lot of oral medication that's also more targeting the T cell and B cells to control the immune system in much more kind of a milder manner compared to steroid. Azathioprine is they're inhibiting the DNA synthesis. So basically, the B cell and T cell are not able to replicate itself. Therefore, as a result, will reduce the pathogenic antibodies. It is pretty well tolerated, although there are also a long list of side effects such as flu-like symptoms, but it's generally speaking very well tolerated, although it does require some monitoring with your cell count and liver function. But really the downside of this medication is it takes long time to work. And because it takes such a long time, we are not even sure it's working. Really, the only way to know that this works is that if we can come off of a steroid as soon as possible, or if can we at least come to the minimum dose of a steroid. So that's certainly a challenge for this medication. And same thing applied, also known as a CellCept mycophenolate. Again, pretty well tolerated medication, milder side effect. However, it's also very slow. It can take up 9 to 12 months to know. So that means usually with the patient with a generalized myasthenia gravis, they're on the steroid at least for a year, which we expect to have some side effect from it. I wouldn't go over other like oral traditional therapy. I would like to look at more time for the new therapy, so I will skip over with the other oral therapy for now. And I want to briefly discuss about other treatment that you're probably familiar with, IVIG. So IVIG and plasma exchange, those are the treatment that's really initially designed for the rescue therapy for myasthenia gravis crisis, which means that the myasthenia gravis is so severe that it affects ability to swallow, ability to talk, and eventually ability to breathe. And if it's unrecognized, it can decline very rapidly to the degree that the patient is unable to breathe. Therefore, the IVIG and plasma exchange was usually done in the hospital setting when patient has acutely worsening of the disease. Good thing is with this neuromuscular disorder, my patient with the myasthenia gravis does respond. And there's a way to treat and reverse the weakness. So IVIG has been used to reverse that, and then it's dosed 1 to 2 grams per kilogram, depending on how it's used. If it's a rescue, higher dose. If it's the maintenance, it's a lower dose. And it's given through the IV. Fast onset, there are some side effects noted, but generally speaking, very well tolerated medication. Again, it's kind of expensive, and it does require the IV access when it's given. Plasma exchange probably have a similar efficacy for the treatment, fast action, and a very good way to remove pathogenic antibodies from the system. However, it is given more over longer period of time, up to 10 days. It's given every other weeks. It's pretty time-consuming processes to go through this. It basically removes all your plasma from the body and then replace it with a new plasma. During that process, there is some risk of removing the healthy proteins, such as coagulating factors, and also it has some risk factor with the reaction to the donor plasma. However, again, very fast, very efficient way of treating the myasthenia gravis. So, we are kind of stuck here. Traditionally speaking, we've been using the IVIG and plasma exchange, the patient with the myasthenia gravis with the crisis, and then once the symptom is better controlled, we use a steroid and we use other immune modulating therapy at the same time until the steroid can be reduced with the other medication takes over. However, this has been very long process of a journey to get into that stage. Other problem is that it takes long time, and usually speaking, the patient with the myasthenia gravis with a quicker diagnosis, a quicker control of the disease, have a better chance to get back to their normal self. So that has been a challenge, and then the new therapy came out. which is really, really promising. And there are two classes of medication, which is FcRn inhibitor and complement inhibitor. It seems like a very difficult way to say it, but FcRn, I will give you the brief history of FcRn inhibitor. Our body is extremely smart. As a doctor, as I study medicine more and more, I just astonished how nature is so smart to have this complex system. FcRn was initially actually discovered in the mouse intestine cells, where this is the maternal IgG immunoglobulin passively transmitted to the baby, so baby can be actually have some passive immunity against the pathogen, which is from the mom. So as a mom, it's so important to give an initial breast milk for the baby to have a good immunity. And FcRn actually plays a role to transfer the IgGs to the baby. And as we study this FcRn more and more, realize the body has a way to recycle the FcRn. So it's just like our plastic industry, where we are trying to now have some of a recycling process so that we can be more efficient and it's cleaner. So what it does is that it recycles IgGs so that we don't have to make new protein all the time in our system, and having this inhibitor will reduce IgG as a result. So there are two medications that are just FDA approved, which is Vyvgart as well as Rystiggo, and there are two in the pipeline that's in the phase 3 trial. So let's go over it one by one. So I will start with the efgartigimod. This is the first therapy, first FcRn treatment that was approved by FDA, and it was approved just about 2 years ago in December in 2021, and recently in June, Hydrullo, which is the subcutaneous one, got also approved. This is approved for the acetylcholine receptor positive myasthenia gravis, and it can be given IV, and then that IV will be dosed by your weight. Hydrullo will be dosed a fixed dose, but basically it's given weekly, and you have it for 4 times, and then there's a break between the cycle. So the break can be actually individualized that becomes really nice for our myasthenia gravis patient. I have a patient who is a world traveler and cannot have a medication all the time. So it becomes really nice that he's bound to the area, getting the IV or subcutaneous injection for 4 weeks, and then they can have like some off time. And depending on how they do, it can be individualized to every 4 on and off, or it can be even longer if the symptoms are better controlled. The other good thing about this drug is that it's fast onset, and I think that's a huge advantage for the patient with treated with this therapy. I'm not gonna describe everything on the graph, but just basically I wanted to show you, compared to placebo group, the patient with the Vyvgart does have a much reduction of their symptoms in the first 4 weeks, and that sustained decline was achieved. And then you can see the their symptom level kind of gradually get back to where they were. So the repetition of this drug can be studied again based on how they do. But basically, they have this trend of going down and sustained effect when they're treated weekly basis for 4 weeks, and that's how the dose was decided. Side effect is pretty mild: headaches, some upper respiratory infection. The study was done like during the COVID era, and so we saw all the side effects, but it doesn't appear to be affecting too much for the risk of infection. The next one that was approved was Rystiggo or rozanolixizumab. That was approved in June of this year also. And the unique thing about this medication is that in addition to acetylcholine receptor positive patients, the study also shows a great effect for the MuSK patient. So this is the only medication that's currently approved for the MuSK positive myasthenia gravis, other than what we clinically observed benefit with the MuSK patient with rituximab, but we won't talk about that for this talk. The rozanolixizumab is also subcutaneous injection, and it's given for weekly basis for 6 weeks. And then again, we can have a break between the cycles, so it also kind of have a nice treatment free time to so that that gives a lot of freedom to individualize the treatment. Again, side effect is pretty mild, comparable to Vivigard. And the fast onset is a huge benefit for this. And very similar graph is shown here, that their symptoms are very well controlled, symptoms are much better controlled in the first week, actually, and then it continued to decline until the 6 weeks, and then it gradually gets back to where they are so that the cycle can be repeated. And again, based on how the symptoms, it can be individualized, which is the strongest benefit of this drug. Switching a gear a little bit, I would like to talk about complement inhibitor. So as Dr. Goyle described, initially the myasthenia was thought to be a disorder mediated by antibody, which is directly binding to the acetylcholine receptor. Therefore, they're competing to the receptor. But not even then, it actually also recruits a lot of inflammation cascade on that area. So if you actually see the slides from the patient who has a myasthenia gravis for a long, long time, this architecture of the muscle on the top of the where the nerve and muscle communicate, it actually got a lot of destruction. And it is because it has a lot of immune attacks over the years. And one of the attack is done by something called the MAC, which is a complex that's formed on the surface of the membrane. And that MAC is formated with one of the complement, which is called the C5b. So what complement inhibitor does is that actually it actually blocks the cleavage of the C5, which is a terminal pathway of the complement. And then it will block the way to make a MAC complex, and also it blocks the way to have a further inflammation in the surface of the muscle surface. So currently, there are 3 medications which uses this pathway: eculizumab, Soliris, ravulizumab, Ultomiris, and zilucoplan, which is Zibrisk. So let's talk about eculizumab, Soliris. This is a year of excitement in 2017 when this novel therapy came out for the patient with the acetylcholine receptor positive generalized myasthenia gravis, which was refractory to a lot of prior traditional medication. The dose is given through the IV. There is an induction dose, and then it was given weekly for 4 doses, and then the maintenance starts, which is given every 2 weeks. There's some side effect, which is most common one is probably musculoskeletal pain and some diarrhea. But it's again very, very fast action within weeks or so. Can see the very good improvement of for the myasthenia gravis. So sometimes it's used in the in hospital setting, and they can be effective and maybe equivalent to IVIG, but that study hasn't been done yet, so we don't know. The one thing that I actually I forgot to talk is that this. I don't know if I can go back. All this complement inhibitor, they required vaccination. 2 doses of a vaccination for each category. There are 2 categories are required, and it's because the patient with the complement deficiency, they're susceptible to certain bacteria, especially the meningococcal bacteria. Therefore, the vaccination is crucial for this to prevent maybe a meningitis, something like that. Despite the fast action, is really we have to wait for 2 weeks so that the vaccination become effective. But in urgent cases, we can still use the antibiotics prophylactically treated just in case that the bacterial infection occurs. As you can tell in this graph, again, the very similar picture, just like a prior drugs, have a fast onset and the sustained effect that's achieved with this medication. And 5 years later, the same company actually got the approval for Ultomiris revolizumab with the same mechanism of action. And the benefit of this medication is the frequency of giving the dose. It can be given every 8 weeks, which is revolutionary. Loading dose is given 2 weeks apart, but then when that's completed, it can be given every 8 weeks, which gives a lot of freedom to the patient, not bounding to the area of living. Again, very fast onset and some milder side effects. The most recently, this new drug got approved, which is called Zilucoplan and Gibrisk. The medication is different from prior because it's a sub-Q injection, and also it allows the patient to self-administrate. This is a huge advantage to give the medication, give a lot of freedom and autonomy to give the medication at home and any time. Fast onset was noted, and some side effect is a milder infection and injection site injection. But otherwise, so far, I mean, it's very, very new. It's just approved a month ago, so we don't have like long-term side effect profile just yet. But it makes our option more broad. So there are more under the development. There's more FcRn inhibitor coming up, complement inhibitor, cell signaling targeting therapy, B-cell depletion therapy is on the way. Also, there may be an era that we can cure the myasthenia gravis. The CAR-T therapy is in phase 1 trial still, but it is on the way. So, overview of treatment. I talked a lot about many different ones. I wanted to kind of give you all the information so that you can have some conversation with your provider. Which one would be works for me? Which one would fit to my lifestyle and your preference? You know, the treatment can be given like oral, subcutaneous IV, and there are also various frequency that can be applied. So this will hopefully guide you in terms of a treatment, and also a lot of different combination can be used and tailored based on your symptomology as well as your lifestyle. So that concludes my talk. Thank you.